All right,
One
while
more
everyone's coming in, I am Jessica Gray. I'm a very informal presenter, so I'm gonna have a lot to share, but I really like participation too. So while people are hopping in, can you just write in the chat if you are a brand new buprenorphine prescriber, you're someone with some experience, or you're a pro? And Jim and Phoebe, you better write pro in there. But for everyone else, just wanted to, just write in the chat so I get a sense of, and maybe where you're practicing, that might be fun, so everyone can do a little bit of get to know each other. As folks are still hopping on. So I sort of designed this topic to be both for folks who are doing this for the first time or who may have had a little experience. And so it's going to be a mixed bag. The idea is that, and I can't see the chat, but if anyone was brave enough to start typing, let me know. The idea is that we spend an hour together. I'm going to share mostly in presentation form, Buprenorphine 101 for the era of fentanyl. And then in 2 weeks, I hope that you guys come back and join us to really dive into some cases with a little bit of a panel around this. So figured I gave this presentation a couple months ago, and there was just so much good conversation to have after that we decided we needed to make it in 2 parts. So did anyone enter the chat at all?
Yeah.
Oh,
this is
I can't
Amy.
see it at all.
We have kind of a mix. We have people that are brand new. We have people that are experienced. We have 2 MCSTAP consultants. We have people from a couple of long-term care facilities, which is great.
Oh, cool.
And so we have a really mixed group in terms of their experience.
That is awesome. Okay, and for some reason, nothing is showing up on my chat, so I officially have no way to communicate with you guys. So I'm going to dive in. How's that? So, welcome all. If you want to mute when you're not, unless you're asking a question, that would be great. Okay, so again, I'm Jessica Gray. I'm a family and addiction doc. I'm one of the MCSTAP team members, along with some colleagues here, and I'm excited to really dive in for the next hour to talk about buprenorphine in the era of fentanyl. And I don't have any disclosures today. So by the end of this hour, hopefully you are more familiar with the nuts and bolts of buprenorphine prescribing. We'll review some buprenorphine induction strategies and their level of evidence, and then explore the impact of illicitly manufactured fentanyl on bup dosing and some of the newer buprenorphine formulations that you may be coming across. So diving in with a case, we have a 40-year-old male who comes to your primary care or SNF office for a new PCP visit, has a history of hypertension, diabetes, and chronic back pain after a motor vehicle collision many years ago, and he hasn't been to the doctor for years. So he tells you he's been managing his pain with buprenorphine that he purchases at about $10 for one 8-2 milligram film. He's been taking 4 milligrams per day for the last 5 years, and he finds it incredibly costly, if you can do the math right there quickly. And he asks very politely, would you prescribe the buprenorphine for me? And so in the next couple of slides, we're going to go through these questions, whether he has a use disorder, why may he have been buying bup, can you treat his chronic pain with bup, and that's my shorthand for bup naloxone. And then what are some of the next steps in thinking about safety, prescribing, harm reduction? So again, I can't see you guys or the chat, so it'll be mostly me talking to myself. But the first question is, does he have a substance use disorder? And so how do you make that diagnosis? This is just a reminder about the formal definition of an SUD. It's a maladaptive pattern of substance use, which leads to clinically significant impairment or distress manifested by 2 or more of the following 11 items occurring at any time within the last year. And so as you can see, the criteria are broken down into mild, moderate, or severe use disorder. And all of them center around the impact that the substance has on the person's life, whether it's behavioral health, time spent using, loss of control, impact on family, friends, social, hazardous use. And I'll just point to the last 2 criteria, which are withdrawal and tolerance, and those by themselves don't define a use disorder. So in this case, we don't really have enough information necessarily to completely make a full use disorder. You might want to ask some questions, but from the information we have, I haven't heard any concerns for anything that would lead to this gentleman with chronic pain to have developed a use disorder, even if he has tolerance and even if he stops the medication and has withdrawal. So those by themselves are alone not criteria. And so then the next question you ask yourself is why was he buying buprenorphine on the street? You know, that has its own risks. And I think really important to know that the stigma around showing up to, provider's office and asking for a medication used to treat a use disorder is incredibly strong. And even I think in 2020, it's sort of last data we have, only about 10% of primary care providers were actually prescribing buprenorphine. So there's not only sort of no access, but people are pretty ashamed and afraid to ask that question of their providers. And so I think the other thing you could think about is, on a positive lens, he's buying a medication, so buprenorphine naloxone, which is prescribed. It comes, if it's the film form, it comes in a sealed package, an individually sealed package. And so you could actually say, wow, he's actually accessing a safe supply without really increasing the risk of accidental fentanyl exposure. So those are things to think about as to why he's spent the last 5 years outside of the medical system. And then the next question is, can I treat his chronic pain with buprenorphine? And so I want to just share some sort of basic tenets, and that is that buprenorphine is actually indicated for both addiction and chronic pain, and there are different formulations sort of for each. So the sublingual formulation that I'll show in the next slide has been approved by the FDA for addiction treatment, and it hasn't been specifically approved for pain treatment, but it can absolutely be used off-label for pain and commonly is. That's different than the parenteral and transdermal formulations that are approved for pain, and they're not approved for addiction treatment. And according to the Data 2000 law, one cannot use the parenteral and transdermal formulations specifically to treat addiction. So if you're actively treating an opioid use disorder, you can't use those medications to do that. You have to use the sublingual forms. And then finally, there's a lot of good evidence that the presence of chronic pain is not a barrier in itself to successful treatment of opioid addiction and can actually really help a great deal of people. So I just threw this in here so that you guys have it, just that you can get it from SAMHSA, you can get it from any of the other sources up to date, but just so there is a little bit of complexity of the conversion between some common sublingual formulations, such as brand name Suboxone versus Zubsolv. And so I just wanted to put this up so that you have access to that. There's 2 milligram, 8 milligram, 12 milligram, 16 milligram films or that correlate to Zubsolv. Okay, so now that you've got all that background, what are the next steps you want to do for prescribing buprenorphine? And this is where I'll turn to the document that we made at MCSTAP, which hopefully you have access to on our website around the nuts and bolts of prescribing buprenorphine. And really, it's sort of meant to walk you through step by step what you should be thinking about diagnostically, sort of a how-to of next steps in prescribing. And we are always here, for a phone consultation if needed. And so the prescribing steps are really several. One is check the MASPAT, the PDMP, with every single prescription. You either need to do it yourself or you need to have a delegate who is linked to your profile. So it can be a nurse in your program that check the MAS PDMP for each time you prescribe. The second is to pick a formulation and a length of the prescription. And I would say in general, like, here and in the guide, we give some general guidelines for sort of the average patient starting out, but there's really no head-to-head trials supporting optimal frequency or dose. And so a reasonable approach is to, for the first month of treatment for someone with an opioid use disorder on buprenorphine is weekly touch with either the prescribing clinician or a nurse in your practice. This is an example of sort of what the prescription looks like. So Suboxone 8-2 milligram films, place 2 films under the tongue daily for 7 days. Again, the document goes into more detail, but essentially there's sort of a stepwise approach for the average patient of lengthening scripts and reducing touch as someone gets more and more stable. Toxicology does play a role in prescribing, although I think there's evolving concepts of that, and so I'm happy to talk about that either if there's time now or in our next session. And finally, buprenorphine is meant to be e-prescribed, so it's a DEA Schedule III controlled substance. In Massachusetts, we do require all controlled substances to be sent via e-script, so electronic prescribing as of 2020. And then since the onset of COVID, we are now able to prescribe buprenorphine using telemedicine. So you don't need a first in-person visit, which is really improved access to the medication. And then finally, it's really important to everyone you see with either chronic pain on opioids or opioid use disorder to make sure that you're prescribing naloxone for overdose prevention and explaining how to use it. Okay, so I shared that's, the rundown on how to write your first prescription, but you heard that you need additional training. And so this is just a reminder to everyone that as of the end of 2022, you no longer need to have the special X waiver to be able to prescribe buprenorphine. And so what you do need, though, is as of this past summer, a total of 8 hours of training on opioid or other substance use disorders, and or board certification in addiction or addiction psychiatry, or be a recent graduate and in good faith standing from one of the schools below, because now all schools are actually covering or should be covering OUD in their treatment. So this counts as one of your hours. We have more ways to support you in getting those 8 hours, but this hopefully isn't a heavy lift and really allows you to learn about the medication that you're prescribing. So thinking again along the lines of this case, this patient who walked in asking for buprenorphine, what else should you be thinking about as you're prescribing the medication? I mentioned naloxone. So even if someone's, no, I'm in remission, I think everyone should carry naloxone with them. And so it's important that if they've never seen it, to explain. It looks like at least the one that, is usually covered and prescribed is a nasal spray, right? So I say it looks like Afrin, and you do it the same way, put it all the way in the nose and fire it. It is safe to use on anyone who does not have opioid dependence. So I teach people that this should go with your prescribed medications. It is safe on kids. It is safe on family members. Good to have around to rescue someone else if needed. And then if someone, of course, who has an opioid dependence becomes over sedated and not breathing, it is life-saving. The other piece, again, along the lines of medication safety at home, we really want to reduce the risk of diversion, thinking about sort of teen exposure to medication. So I recommend that people keep their controlled substances locked up, and again, with naloxone there. And then I'm going to talk a little bit in the next couple of slides about how we think about what's going on with the adulterated drug supply in Massachusetts and the US, and how to think about and talk about that with our patients. So this awesome QR code is one I recommend grabbing, but you'll get all the slides here. And so Brandeis does a really beautiful job leading the way in helping us understand what's in the drug supply in our state. And so this snapshot is one of their briefs looking at what are the active substances detected in drug samples. You can see that fentanyl and coke are sort of leading the way, with xylazine, other analogs, and a lot of other substances and medications and contaminants seen in the drug supply. And so what Brandeis does, what the MADS Massachusetts Drug Supply Data Stream Update does, is they actually put in regular updates when they notice a concerning trend. And I think so it's helpful to be on the radar for that. And the first one, so in 2021, they shared information that there were a significant number of fentanyl analogs being found in our drug supply. There's fentanyl being found in cocaine. So if the coke is cut in the same place where fentanyl might be cut, there's contamination there. What people are used to think of as heroin is now contaminated nearly completely with fentanyl. And then there's a lot of pressed pills being sold as other medications that are fentanyl. In 2022, they put an update out about the xylazine that we're seeing, in the drug supply. So this is a veterinary tranquilizer with alpha agonist properties. You may have seen just really some of the awful skin ulceration that folks are at risk for if they're injecting it. And at that time, it was found in 1 out of 4 fentanyl samples in our state, so pretty significant exposure. They also put information out about counterfeit benzodiazepines in our state. So there was a rise in designer synthetic benzos that are not detectable by sort of the standard urine assays or oral assays that we use. And so knowing that that can complicate oversedation, that can complicate overdose withdrawal, and you would not know that your patient's taking it without really having an open and honest conversation with them. And then finally, the other adulterant I want to highlight is that in the stimulant supply that we're seeing, which is really an uptake in methamphetamine in our state, but also phenacetin and cocaine, which is a sort of acetaminophen derivative. Okay, so with that,
sorry to interrupt. No,
yeah.
There's a couple of questions that I thought you might want to get from the chat.
I can't see the chat, but go for it. Yeah.
Okay. One question was, is xylazine ever prescribed to humans?
Not that I'm aware of. Good question. Nope.
Into whatever.
Oh, I can see the chat now.
And there's another question. Do you know of any website that can tell us providers how much approximately these drugs cost on the street? I find myself asking patients this, but it would be interesting if there was a study of this.
Yeah, I think Reddit might have stuff, sort of some of the online chat forums, but I just ask my patients, and that's how I get the sort of local knowledge. And it really differs by different parts of the state. So I think it's evolving and very sort of localized to different parts of the state. And Phoebe and Jim jump in and add stuff if you have thoughts on that otherwise. But I don't know of otherwise like a sort of centralized website to do that. Were there any other?
It looks like Sarah Lennox has her hand up.
Hi, Sarah. Yes.
Sorry, I can't seem to enter anything into the chat. Can you enable that?
I have no control. I can't even see the chat. So do you want to ask a question?
Not specifically at the moment. I just wanted to be able to put them in there, but oh, now there's an arrow that says new messages. Maybe that's what I need.
All right, awesome. Okay. Well, Amy, if you don't see any others, I'm going to keep going, and then people can always keep interrupting me. That's perfect. Okay. So what do we do in this case? I hope that everyone in this room feels comfortable that, hey, this is someone who I should just start on this medicine, right? He's been taking it with good effect. He's using it to treat pain. He's taking it once daily at a dose of 4 milligrams a day. I'm going to start prescribing. I'm going to see him back regularly. And the beautiful part is then I'm going to actually work on all the other health needs that he has. So now that I have him in to the healthcare system, I can work on his diabetes, his hypertension, and he does quite well. Okay. So in the next case, I really want to think about buprenorphine inductions. And so this is a 38-year-old who's in your practice for a new patient visit. You review the chart, and the patient was seen in the ED 2 weeks ago for an opioid overdose that required naloxone. He left the emergency shortly after that with a buprenorphine naloxone kit. So that's in some emergency rooms where they sort of give out, instead of a prescription, you get a kit of 6 films to go, and has since started using again after that emergency department visit. And so you have heard about the substantial mortality benefit of medications for opioid use disorder, and you decide to offer buprenorphine. So again, sort of what are those initial questions that are going to come up for you in the beginning prescribing? So thinking about what are the first steps in evaluation of this patient? Thinking about how high potency synthetic opioids, which includes fentanyl, can impact getting your patient induced on buprenorphine. And then really, again, what else should you be thinking about for safety and harm reduction? I'm going to go through these pieces. All right, so what are the first steps in evaluation? I was going to have people put it in the chat, but I can't see the chat, so I'll just talk it through. But essentially, it really comes down to taking a good history, right? You can get 99% of the information you need from a patient sharing their history with substances, where they're at in terms of their use now, and what's worked and what hasn't worked in the past for them. Toxicology has a place and can be done in that first visit, but we don't recommend waiting for the results to come back to start treatment. So really, people should be able to walk in and get treatment same day with a good history. In terms of your exam, it can be as limited as making sure that the patient is safe and breathing. It is useful to understand potential to have an exam that looks for complications, such as infectious complications, skin and soft tissue infections, other pieces, but again, not required for making that first evaluation. And then in terms of lab work, there is no required lab work on that first visit. It's helpful to get some basic screening lab work based on what the patient's at risk for. So thinking about infectious risks, hepatitis, potentially, STIs, liver function, all those things are helpful, but again, should not hold up starting medication. Okay, so the next question that's important to be on your mind is whether there's been any exposure to fentanyl, and how do you need to really think about the induction because of that. And again, as you saw, sort of fentanyl is the norm in Massachusetts, and so you should anticipate that it is in the drug supply of your patient. And so wanted to review why this matters so much when you're inducing someone on buprenorphine. So buprenorphine is a long-acting partial agonist, right? So it acts at the mu receptor, but unlike full agonists in green, it only partially partially activates the mu opioid receptor. And what that means on a really positive note is that we have pretty minimal respiratory suppression compared to a full agonist. And when used as prescribed, has not been shown to lead to respiratory arrest. It does have a very high affinity for the mu receptor. So I like to describe to patients that it will get on those opioid receptors and it will hug them tight and not let go. And that means that it actually is what's protecting you from an opioid overdose if you use fentanyl after it. So it's not the naloxone portion of the buprenorphine naloxone, it's really the buprenorphine's high affinity that is the overdose protection in this medicine. That also means, though, it will displace other opioids. So if you are using fentanyl, if you're on full agonists for for any reason, the buprenorphine will go on and shove off the other agonists, and that leads to a really miserable state called precipitated withdrawal that I'll walk through. And I think the last major feature to keep in mind in buprenorphine that it tends to slowly dissociate from the mu receptor and sort of stays on for a long time, and that really allows us to think about different ways of inducing. So pre-fentanyl, since we started using buprenorphine, really the traditional buprenorphine induction was what everybody recommended. And so for a traditional induction, the patient needs to be in mild or moderate withdrawal. We use Cow's scale. We know very clearly that it is safe, appropriate to have a patient be in their home or in the office for induction. Most patients do prefer it at home rather than sitting in your office all day. So important to know that. And it's important to give patients choice and know that often being in the comfort of your home is much more comfortable and patient-centered. And then it's really important, I'd say, listen to your patient. I find that they know much better than me and have often tried buprenorphine before and can either share stories where they've had no problem or had trouble getting on the medicine. And so the traditional bup induction, just to go very briefly, is waiting until the patient's in moderate withdrawal, which varies based on the agonist they've been exposed to. Taking a 4 milligram dose, waiting 4 hours or 45 minutes. If you're sick, take the next dose, and then repeat that in 4 to 6 hours again, up to 12 milligrams in this schema, and then sort of starting the next day at 8 and 8. I would say I'm sharing this briefly because a lot has evolved since then, and so this, I would say, applies to a very, very small portion of patients who are getting on buprenorphine. And so again, why do we worry so much about the induction process? That is the only hard part about buprenorphine. The rest is easy because we really worry about that differential. So again, knocking someone into precipitated opioid withdrawal. And we define that as the rapid onset of objective signs of withdrawal, which usually occur within 30 to 60 minutes after the initial administration of buprenorphine. And the patient feels like death, right? So you have all the signs of severe opioid withdrawal, up to restlessness, vomiting, diarrhea, sweats, chills. And, in academics, it's defined as a change in COWS by greater than 5 points. In practice, it's sort of going from feeling not okay or not great to feeling awful. So it's that abrupt change. And, the concern of precipitated opioid withdrawal is really that it's absolutely miserable to do this to a patient or for a patient to go through this. It's incredibly stressful for the medical team to watch. It mostly leads to a return to use because someone feels so awful. And that experience really can traumatize someone to not want to use buprenorphine in the future. And this is a really, it's one of our only 2 incredibly evidence-based medications. And so not losing that option is really a problem. And I think the other challenge that we can speak to is just that because of the tremendous variability of withdrawal with the illicitly manufactured fentanyl, it really it's hard to predict when someone is sort of at the point where they can start a traditional induction. And the other thing is to have a broad differential diagnosis, right? So when you see someone who looks like they might be in precipitated opioid withdrawal, they're actually it's important to think about what you could be missing. So is it undertreated withdrawal where essentially you haven't sort of filled the receptors sufficiently to match the level of dependence and tolerance that someone has on a full agonist? So, just sort of miserably untreated withdrawal, but not acutely precipitated, or sort of the natural course of withdrawal. Could they have another substance on board or be withdrawing from another substance that could mimic opioid withdrawal or be actually concomitant, happening at the same time? Or are there medical conditions that maybe there in terms of thinking about sepsis, DKA, other pieces? So just things to keep in mind broadly if you see this. And so I talked about buprenorphine. Now I just want to talk a little bit more about what we know about fentanyl and its analogs. And so we know that it rapidly crosses the blood-brain barrier. Fentanyl is 50 to 100 times more potent than morphine, and that potency in street fentanyl varies widely. It's highly lipophilic. There's rapid fat sequestration. And, there's been interesting studies showing that regular use actually leads to delayed renal clearance. So for someone who's a pretty heavy or regular user of fentanyl, we get this fat sequestration. It's then slow to leave the body. And so in this one study, it took about 2 weeks for the fentanyl to totally clear, and it could take more than 4 weeks. And we see in pregnancy it can it can linger even longer. And the other important pieces that I mentioned is that because of the heterogeneity of the different fentanyl analogs and because of the individual, we really see an unpredictable withdrawal course from fentanyl that really complicates getting on buprenorphine. So in all this, I want to highlight a great article that came out in 2022, which really talked about a plea from people who use drugs on needing to have better ways to initiate buprenorphine than in the fentanyl era than just the traditional induction. And so this is a summary slide from a colleague, which is trying to sort of give you a sense of the different options for inductions that we have these days. So the standard, you can see in this sort of first column, was what I talked about, otherwise known as traditional induction. I'm going to talk more about low and high dose inductions, and then the low dose induction with a cross taper of the full agonist is the other one. Looking at the time here, I think we're okay. So thinking about buprenorphine inductions, I want to really highlight two emerging strategies to think about, especially sort of in this patient who you saw. And so high dose buprenorphine inductions, and this concept is rather than the traditional induction you saw, which you stop all opioids, you go into withdrawal, and then you slowly sort of take buprenorphine over the course of the day. The idea here is that by flooding the receptors with buprenorphine, you minimize the period of undertreatment of the patient, and you rapidly maximize the agonist properties of the buprenorphine, and provides a quicker protection against overdose because the patient's on a therapeutic dose quicker. This is, I would say, sort of both of this and the low dose are really experimental. So there's been, case reports and case studies sharing people's experience with this, and in the emergency room, in outpatient, in the field, so with paramedics, and less documented in the outpatient space, so more in controlled settings. You must be in withdrawal to start to do a high dose buprenorphine. In general, the sort of cases that are out there really target getting greater than equal to 24 milligrams in the first doses. So it could be like 16s or 2 films under your tongue when at the first pass, and then another 2 films under your tongue subsequently. The challenge in all of this is there's really no consensus on optimal timing of how sick you should be. So what the COW score should be, what the timing between doses should be, and then what the actual sort of target dose is. And again, this has been really variable in the literature and based on clinical experience. I think the take home is if you're going to use this method, there's no middle ground. You need to be aggressive and really get a lot of buprenorphine on board. And use comfort meds, and you can use comfort meds too to support. And so the sort of avoid the middle ground, I say sort of go big or go home, like really flood the receptors with buprenorphine. That doesn't mean that they stay on that high of a dose, but that it's just that sort of initiation. And here I just listed some of the literature case examples that we have. So again, in the pre-hospital EMS and post-overdose literature, folks have been giving high-dose buprenorphine. People have done it after naloxone self-administration, and been shown in some emergency department with Gail D'Onofrio in a national study. Okay, so that was high dose. And then thinking about another emerging strategy that is commonly used around the country is now been dubbed this low-dose buprenorphine opioid crossover or opioid continuation. It used to be called low-dose induction. So it has a couple of names in the literature, but essentially what you're doing is you're continuing someone on their full agonist, and you inch buprenorphine on to the receptors in very low doses over anywhere from 2 to 7 days, so that the patient doesn't experience sort of the whopping load of buprenorphine, but that it works by theoretically, putting a little buprenorphine on each day so that I like to describe it as putting your toe in ice water, then your foot, then your ankle, rather than sort of jumping into the ice water. The initial doses are usually, again, vary by clinical protocol, but usually 0.5 milligrams or less. We have a lot of, sort of different case series out there. There's a one pager that you can see on the QR here. And I think the tricky part is that, there's no standardization here. There's no sort of gold standard trial been done, but in different settings, people have used IV, buccal film, transdermal patches in the hospital, and then outpatient more sublingual films or tabs, because that's what is readily available. And so here's just a list of some of the different low-dose bup crossover protocols, and so that have been published. So, for example, you can see, columns are the days. So you would start with buprenorphine 0.5, take it twice a day, increase it sort of double the dose each day, and that's pretty rapid. And then once they're on, 8 to 12 milligrams in different protocols, you then stop the opioid agonist completely, and then just continue to bump up the buprenorphine. And you can see in some of these, there's buccal buprenorphine, which can just come in smaller doses. So, and you can use micrograms there, which can make it easier to get those lower doses on, and then switch to the films, which is the more common prescribed. And so with all of this like spinning in your head, how do you then approach the patient to have a successful buprenorphine induction? And I would say the number one is really making sure that you're putting patient preferences first. Again, let them lead, let them share what they've experienced, what they've tried, what they know, what they're comfortable with, because that will get you a long way to figuring out what approach is right for them when there is sort of no gold standard at this point. Timing matters. So for folks who are using prescribed, full agonists, it may be a little, or our methadone, for example, and are transitioning, that may be very different than someone who's actively using fentanyl in terms of the risk of continuing the full agonist. Someone may be out of their, their agonist and really want to stop using. And so that might influence sort of the timing and what type of induction you choose. Location matters if you're in a SNF versus if you are outpatient. Does the patient have a home to do this in? Sort of what that could look like. Are they willing to go into supported environment to get this done in a medically assisted withdrawal or detox, where really they should stabilize on the medicine? What are your clinic resources? Are you only open Monday through Friday? Is it hard to do this on the weekend? Are there nursing, staff or other staff that you can call on to support this patient? Are important to think about. And then again, the agonist properties of whatever the patient is exposed to.
Just before you go on, there was one question I just wanted to share in the chat. Can you describe, in regard to case one, could you describe whether in that case you would recommend buprenorphine for pain versus Suboxone?
Yeah, so that's a great question. So you are treating his pain because he doesn't have a use disorder diagnosis. So I would treat his pain with off-label Suboxone. So if he's identified that 4 milligrams of Suboxone works great for him, then I would I would go with what works. It's important to know that the treatment, the formulations available for pain are in micrograms, so versus milligrams for addiction. So it would be very hard to sort of get to a dose that adequately treats his pain with Bunavil and some of the other formulations that are really meant for opioid naive folks getting pain treatment. Jim.
On that note, would you recommend that the patient starts dividing his dose? We usually recommend buprenorphine be dosed maybe 3 times a day. So would that be 2 milligrams twice a day, or how does he split it even more? How would you approach this person?
No, I think that's a great question. So even though, to Jim's point, even though labeling says that, it's a once a day medication, we find that most people really do divide it up into dosing. And we know the analgesic properties are really 6 to 8 hours. So people with chronic pain often find that, taking the medicine BID or TID is really helpful. And so again, following his lead, I would ask him if once a day is working beautifully, perfect. You only have to take a medicine once a day. If he's not getting adequate pain relief later in the day, then I would suggest cutting it in half to do a lower dose divided out through the day. Thanks, Jim.
And then
mhm.
there just and then the person that asked that question said, I guess I don't understand why people prescribe Subutex since it does not have the added naloxone.
Yeah, good question. So Subutex is just the mono product of buprenorphine. It is used to be a lot more prescribed, but because insurance companies switched to the combination product, it's just harder to access in some states, whereas other states it's on their, higher on their formulary. So a lot of this is sort of what's available in your state. Buprenorphine naloxone, the combination product, was sort of billed as a better a better medication because it deferred abuse and diversion and misuse. The concept is that when you put the film under your tongue or the buprenorphine naloxone, the naloxone's not absorbed. And so it's not really bioavailable that way. And so it acts just like the mono product for the most part. But when if you were to try to inject the buprenorphine or otherwise, sort of use it in a different way, then the naloxone part of the buprenorphine is more bioavailable, and so you would feel sick or not get the full benefits of bupe. So it's sort of a gimmicky way to potentially, hypothetically, keep the medication safer. Although I think really it comes down to honestly availability for insurance, and it's hard to get the mono product approved. In Massachusetts, at least, you need to have like a real indication, such as an allergy or a severe contraindication, or you're pregnant.
Okay, and then Sarah Lennox has her hand up.
Sorry, I can't put the question in the chat. In case 2, are you making the assumption that the person who's coming in to be seen has run out of the initial prescription that he was given in the emergency room? And do you have do you take into account, or is there relevance to what he was using prior to going to the emergency room?
Yeah, that's a great question. So I can't remember how many days between when he went to the emergency room and came to you. I would assume that's probably long gone unless he brings it with him, right, or has it, which is, great. You can sort of start with that. But, if he still has the medication, then you can sort of begin with that. Otherwise, I would just assume he doesn't and need to start prescribing. Again, that was a dispensed medication. It wasn't prescribed, so you wouldn't see it on, it shouldn't show up on the pharmacy or anything. In terms of his use pattern, yeah, thank you. I didn't really get to touch a ton on that, but I would say that it's really helpful in that history that you take to understand the sort of the amount that someone's using, how they're using it, sort of how frequently they use it. That can give you a little bit of a sense of how severe their dependence is, right? If someone's sort of needing to inject, 6 times a day, they're versus if they, are maybe using less or have cut down significantly from a couple grams to a half a gram. So I think those things are helpful in the broad sense of once you see a lot of folks, you may get a sense of severity. I think the reality is we don't know how that translates to, in many ways. And so I'd say both listen to that history, it sort of gives you a sense and you can see how they might be cutting down or where they are. But I wouldn't use exact numbers to sort of translate into something specific as how you then move to sort of start treatment. Does that answer your question, Sarah? I do think though how they.
Sorry.
I do think what's really important is what does their use pattern look like in the last few days, right? So you want to know, when is the last time they used? Was it just before coming in because they didn't want to feel sick when they were talking to the doctor? How frequently they're using. If they did try the Suboxone since they left the hospital, when the last time they took that was, how did it go? Those are some really important questions as you're thinking about getting them onto bupe.
And then just one
polysubstance use and how that might affect your decision for how you were going to initiate.
Yeah, the answer is polysubstance use. It's important to think about what else they're using, and you want to think about what's life-threatening. So if sort of you're worried they're actively using alcohol and that they're going to withdraw, that is maybe a reason to sort of ask them to go to a higher level of care to get off both of those at the same time in a supported way where they really can be monitored. If their goal is not to stop drinking, for example, or not to stop using benzodiazepines, then I really focus on let's get you onto buprenorphine. I don't really sort of care about those other medicines. This is going to be much safer for your opioid use disorder to get you on this partial agonist, which we know has significant protection from overdose. So I would say, maybe in level of care that they're interested in or what their goals are for those others, but this is the first thing I often treat is like, let's get you on a medicine that we know is life-saving and can stabilize your opioid use disorder while we work on the rest. And again, the FDA has come out, I didn't say this, but a couple years ago saying that you should not withhold treatment with buprenorphine for folks who are on benzos. So it really is recommended to treat their opioid use disorder. I'm going to keep going. These are awesome questions. Okay. So now just pivoting a little to think about that case again, how we think about maintenance buprenorphine dosing in the age of fentanyl. And so this is your 38-year-old now status post the induction. I'm leaving it vague because I think there are a couple ways to skin the cat, and has now been seeing you weekly for visits for the last 2 months and is taking 8-2 milligrams BID, so a total of 16 milligrams a day of buprenorphine. And the toxicology testing you're getting is persistently positive for fentanyl. And so your questions are really, is treatment working for this patient? And how can I optimize his medications and keep him safer? And so the important points here about is this treatment working is ask the patient where his use has been. So just like Sarah said, getting a good history about how much they were using before is really helpful because then you can have a sense of how this medication has changed their use pattern. How frequently they're using, have they cut back on the amount? And what you learn is actually that this patient feels better, but is still using at the end of the day because still doesn't feel great throughout the whole day. So it was cut back dramatically on their use, but either daily or a couple times a week still needs to use fentanyl to feel normal. And the next part is how can I optimize his medication to keep him safer, which we'll talk about. So this is a study that's starting to get outdated from 2016, but I really like it because it shows that it is unrealistic to expect that someone's opioid use disorder will magically improve overnight when you start treatment. We anticipate that it takes several months for some people to extinguish their illicit use or their full agonist use if that's their goal, right? And so while the medication is life-saving and magical, oftentimes there's more that is needed, and sort of that don't anticipate that first dose is going to magically cure everyone. There's work to be done. So again, very typical that we would see ongoing fentanyl at the beginning of treatment and continuing. And that doesn't mean that treatment's not making some important impact. Another study I want to highlight that actually came out this past September is really thinking about, there's a growing body of literature that supports that we are underdosing patients on buprenorphine in the era of fentanyl. And so this paper showed that those who are kept on a higher dose of 24 milligrams overall had increased treatment retention compared to those who are kept on 16 milligrams. And I think this case is a good example where this is someone who treatment is somewhat working, but we haven't optimized the dose. And so I would bump him up to 24 milligrams to see if that better captures him and allows him to feel normal all day, to work, to target the cravings, and to help reach his treatment goals. The other interesting articles that have come out recently on this topic sort of challenge the way we think about what an optimal serum level of buprenorphine is. So, we sort of used to think that above 1 or 2 nanograms per milliliter of a serum level of buprenorphine. So again, not the dose that you're ingesting, but what your serum level looks like is sufficient for cravings, for overdose protection. And what we're finding in the era of fentanyl is actually that that floor may actually need to be higher than we thought. And so there's sort of growing evidence in human lab studies that 3 or 5 nanograms per ml were most effective at protecting against fentanyl-induced respiratory suppression. And so sort of more support that we need to be changing our prescribing practices in the era of fentanyl. And so this is just a highlight from one of the papers, which really says that current FDA guidance of buprenorphine dosing recommends a target dose of 16 to 24 or 4 to 24 milligrams. But there's decades of independent research to establish evidence that individualization of doses, at least up to 32 milligrams, increases patient safety and retention in care. And so these strict dosing limits that we face, requiring prior authorizations and other hurdles to get patients the medication dose they need, is really harming patients in the context of widespread lethal fentanyl use. So important papers coming out and thinking about how you are prescribing this medicine. I have just 2 more slides, I think. So I wanted to really briefly touch on long-acting buprenorphine formulations. And so these are injectable buprenorphine that we now have 2 options, which is very exciting, that are allow for a slow release mechanism of buprenorphine so that you're not taking a sublingual formulation 1 to multiple times a day. And some of the benefits are that they provide higher and more consistent serum levels than our current dosing. And so as we think about sort of the floor we need for optimizing patient dosing, they're an interesting option for patients who can't stabilize on their current dose. So if you're someone who is sort of maximizing their sublingual formulation, if they maybe unstably housed or can't hold on to their medications, these are reasons that they may do better on an injectable versus a sublingual. Important to know and to tell patients that it actually takes 4 to 6 monthly injections to reach steady state. So we are finding some real world data that we do need to supplement most people who are coming off of active fentanyl use, especially in sort of that build-up period for the injection. It's not unexpected that patients, again, may have some withdrawal symptoms that need to be treated, or there's ongoing use. And so oftentimes the recommendation would be to continue extending the loading doses, specifically thinking about Sublocade beyond the first 2 to 3 months, and then again, continue sublingual. There's emerging use for XR formulations in buprenorphine induction, so I think more to come on that, as well as rapid starts. So Brixadi, which is the formulation that just got FDA approved in the US, but it's been in Europe for a while, was studied in emergency room settings. There's a weekly and a monthly version, and so they sort of studied using the weekly formulation to induce people on buprenorphine with good effect, and that medication just became available on the market this fall, so hasn't reached a lot of us. The interesting, I worked with it in a NIDA trial for pregnant people this past couple of years, and it just, it's nice to have another option that allows for sort of more flexibility in dosing. So that's the whirlwind on buprenorphine formulations. They are XR formulations. They're not for everyone. Good old sublingual is still the way to go first. But there's maybe some indications where a patient would benefit from the long acting. So my take homes are that prescribing buprenorphine is a life-saving, rewarding, and really, minus the induction, straightforward process. Inductions is where it can get complicated. Please lean on us at MCSTAP. We're happy to support. Also, bridge clinics have a lot of experience with this, so that's another place that you can reach out for sort of a send and return if you have a bridge clinic that is near you. Each of the induction approaches has risks and benefits that are important to discuss with patients. For the low-dose bup crossover, specifically, really consider the safety of the opioid continuation in patients without close follow-up. So that's sort of one of the hardest things I think to think about. Consider the high dose approach as a way to quickly stabilize individuals at very high risk. For those unstable, consider a rapid transition to long-acting buprenorphine. Again, really expect maintenance doses to be higher in fentanyl, in the fentanyl era. Make sure everyone has naloxone. And really don't forget methadone. This is a buprenorphine talk, but methadone has a lot of really, really strong evidence for being life-saving and effective. So buprenorphine may not be for everyone. And so I have, look at me, 4 minutes left to talk more. And then again, the whole point of this is to really set the stage for some more case-based discussion in 2 weeks.
Just one question that came in is regarding case 2. What language do you use to tell someone to keep using their street opiate or like fentanyl while you're starting the bup induction? And how do you document that in your notes?
Yeah, it's a great question. So it's a risk. You want to document a risk benefit shared conversation. So I'm not saying to someone go use, right? I'm saying there are several options of the way to get onto buprenorphine. We've talked about a traditional induction. We've talked about a high dose. We've talked about low dose. Patient has been unsuccessful with the traditional dosing, and in the realm of helping the patient get safer, we recommend this crossover to try to stabilize them. And the way I talk to patients about it is just that. It's that it is our goal is to get you off of this, off of the full agonist as quick as possible. I wish that we had, ideally, we could go get someone into treatment. Some folks, in some emergency rooms and in growing other places, we have the ability to actually give methadone or other full agonists, which would be a heck of a lot, safer, and having a safe supply is much preferred than what we have right now. But now it's that conversation of, unfortunately, like, you're gonna, one of the methods is to keep using what you're using in as safe a way as possible while you get buprenorphine on board. And so, I make sure that I'm talking about all the harm reduction pieces with that, which is don't use alone, do a small tester dose, carry Narcan. There's now a great hotline in Massachusetts that you can call so that if you are using alone, someone can talk you through it and call 911. So I go through all of those harm reduction principles in detail, because it is a very high risk time for patients. And again, I'm like, our team is talking to someone daily if they're doing this low dose induction. Phoebe or Jim, any other comments to add to those? Or other comments in general? No pressure.
Can I ask you a question?
Yeah. Hey, John Foley.
Yeah, sorry, I've asked too many questions today. I work with Jim Ledwith, by the way. He's great.
I agree.
And he's wearing a spiffy shirt too. I was just wondering, because regarding my last question about Subutex versus Suboxone, I just don't understand, because you could, inject Subutex and get high, right? If it doesn't have the naloxone in it, right? Mm-hmm. So I just don't understand why people would prescribe that over Suboxone.
Yeah, that's a great question. So, there's a lot of people who really have intolerance to Suboxone, right? And don't feel as well, and it may have allergies, or other headaches or other symptoms that where the naloxone is not good. I do ask my patients how they use it, and if someone is injecting or has injected Subutex, then buprenorphine, or in jail, put it in their other places where they can absorb it, then I would say that doesn't sound like it's the right medicine for you, right? And so, I think you can misuse any substance, and people do, so I think it's really having an open and honest conversation about how someone's using it. I'm online, but I'm going to say, if they have IDU, is it the worst thing that they're injecting Subutex as a safe supply versus like fentanyl? Well, not that I want anyone injecting it, but I think you have to, I think we can take, we need to take all those things into consideration. And I think there is a role for Subutex for those who can't tolerate it.
Yeah.
And it is actually a heck of a lot cheaper too. And right, this is a generic medicine that can be more readily available. So I do think there are indications to use it. And I think in some states, actually, that's just standard of care. And so, yeah, I think just having open, honest conversations with your patients on how to use it, how they're using it. And if you can do those conversations in a non-stigmatizing, non-judgmental way, then oftentimes they're honest with you.
Thank you
And I
so
found that
much.
people have shared that, yeah.
I've even encountered patients who injected Suboxone, and
Yeah.
they can get high. I guess they're not going to have as much overdose potential with the naloxone in there, but it doesn't give a full blockade on top of the buprenorphine. I did add a comment in the chat about the fentanyl positive test persisting after you do your induction. And one thing to keep in mind is you got a fat depot of the fentanyl. So the next week, the next couple of weeks after induction, you may still see positive tests for fentanyl. And the patient isn't necessarily using. It may be that the drug is slowly clearing the system. So don't threaten them that they must be using still when in those early weeks.
Totally. Thank you. I see we're at time. If there are other questions, can you maybe email them to us so that you don't forget them? And we will be sure to incorporate them into the next conversation in 2 weeks. If there are cases that you have that you want discussed, this is a great time so that I can make sure that we answer them, but it's going to be more freeform. We have a couple of cases to sort of get thoughts flowing and have a little panel to talk about this stuff. So thank you guys so much for joining us.
Thanks a lot.
Thank you